Good morning, everyone. My name is Darshan Mehta. I'm the medical director of the Benson Henry Institute for Mind-Body Medicine and director of education here at the Osher Center for Integrative Medicine. And it's my pleasure to introduce our speakers. But before doing that, just wanted to highlight a couple of things. We have number one, this is on the first Tuesday every month, we have a Grand Round series, and we alternate between our clinical Grand Rounds and our research Grand Rounds. And next month will be Dr. Samia Mora from the Brigham Women's Hospital, who will be talking about Mediterranean diet to reduce cardiovascular disease and other chronic diseases of aging. So really a wonderful talk, and look forward to that. And then the other, just wanted to just put in a plug. The Osher Center is involved in an upcoming conference at the end of June in Burlington, Vermont. It's a Society for Acupuncture Research, and it is a conference on acupuncture research, healthcare policy, and community health. So information is out there. So please, we look forward to having your presence at both events. So with that, it's my pleasure to introduce our speaker, Dr. Ryan Zaklin. He's a physician based currently on the North Shore area, but is very well known to us. He did his internal medicine training at Massachusetts General Hospital. I actually had a chance to get to know him as I began my work there at the Benson Henry Institute. And then since then, he's moved on to bigger and better things, including currently he has a private practice in integrative medicine and Cannabis Therapeutics. And he also does work in partners with geriatric patients in skilled nursing facilities. So with that, he will then introduce our patient as well as our discussant. So, Ryan.
Thank you, Darshan. This is that bigger and better thing that he was referring to. So I'm just going to jump right in with our patient, and I think we'll get into a little bit of a discussion after Dr. Levy and my presentation. So thank you, everybody, for listening. I'm going to talk about the endocannabinoid system in Cannabis Therapeutics, and we're going to use peripheral neuropathy as a kind of springboard. So disclosures, I have no relationships with industry pertaining to this presentation. I do have a private practice in integrative medicine and Cannabis Therapeutics. And I want you to really take away from this, I want you to understand, if you haven't heard of the endocannabinoid system, I want you to have a basic understanding of what it is. If you've heard of it, I want you to glean a deeper understanding of what it is and what it may be, as well as some very basic cannabis therapeutics principles, and also appreciate cannabis as a part of an integrative approach. So we're going to start off with our case. We have Mr. Hicks here. He's a 79-year-old male with idiopathic peripheral neuropathy. He's got a past medical history of coronary artery disease, hypertension, hyperlipidemia. He had a melanoma that was resected, right foot drop, and he was diagnosed with idiopathic peripheral neuropathy. He has allergies to codeine. When he arrived to my practice, these were the medications he was on. He was not on gabapentin prior to his diagnosis, and I believe he also was on ibuprofen, which is not on this list. He's married, does restoration work of historic windows and doors. He does not use tobacco and only occasionally use alcohol. And basically, he has a history of bilateral lower extremity numbness from the knees down, started several years ago. He doesn't know exactly when. He describes it as electric shock sensations in the lower extremities. They're worse at night. He started having difficulty standing for long periods of time, which is when he noticed this. And the symptoms start around 5 p.m. Also has neuropathy in his hands. He was ultimately diagnosed with 2 EMGs and a set of labs, which diagnosed him with idiopathic neuropathy. He was started on gabapentin, which was somewhat helpful when combined with large amounts of ibuprofen, and he actually tried his friend's cannabis and noticed instant relief. He tried it several weeks later. It wasn't as effective, but it definitely piqued his interest. So just a little bit of background on neuropathy briefly before we hear from Mr. Hicks and his experience. So these terms are somewhat interchangeable. Polyneuropathy is really generalized. It's a homogeneous process, and it affects many peripheral nerves, mostly the distal nerves. Peripheral neuropathy is a less precise term and is used synonymously with polyneuropathy, but can also include radiculopathies and mononeuropathies, one nerve. And then neuropathy is often used synonymously as well, and that can be even more generalized and can involve disorders of the central and peripheral nervous system. So the causes, there are many different causes. The most common ones would be diabetes, long-standing HIV, critical illness, also end-stage renal disease, vitamin deficiencies, hypothyroid. Toxins can cause it, or interestingly enough, vibration-induced prolonged cold or hypoxemia. But look at the bottom here, 46% are idiopathic, meaning we don't know what's causing it. So how do you work it up? History, right? The mystery's in the history always. Past medical history, family history. I left the social history off there, but the fact that perhaps he works with, restoration might have contributed to his neuropathy. Labs, these are the labs that are typically drawn, as well as your basic labs. And then an EMG will confirm the diagnosis. So how do you treat it conventionally, right? You treat the disease process, which doesn't always reverse it. You reduce the toxin exposure, also doesn't always reverse it. And then you manage the symptoms. Gabapentin is the kind of go-to. You can use Lyrica, tricyclic antidepressants, other pain medications, and you try to minimize complications, such as with diabetic peripheral neuropathy, foot complications. So that's the conventional approach. But why don't we hear from Mr. Hicks now, who will describe kind of what his experience has been with the conventional approach and his bridge into using cannabis. So, Jim, whenever you're ready, we'd love to hear from you.
Okay. Can you hear me now?
Yes.
Good. I unmuted. So you gave the history very well. That's pretty much what was going on. My wife has a house. I'm in New York City right now. I'm based in New York City, more or less, but my wife has a house in Massachusetts, so I go back and forth a lot. Anyway, I was having a lot of trouble trying to manage the discomfort of the neuropathy, and as Dr. Zaklin said, mostly at night or in the evening. Starting more or less around 4 or 5, and then maybe ending in the middle of the night, because when I wake up in the morning, it's sort of not so bad, and I don't need medication then. So I said, and I was using a ton of ibuprofen, 10, 15 tablets a day, 200 thing a day, and it still wasn't doing particularly well. At night, I'd go to bed and I'd start to go to sleep and my legs are killing me, so I get up or sit on the edge of the bed and rub them and whatever. And so eventually I'd be able to go to sleep, but it was really not a great process. So then I thought, oh no, that's what it was. My friend got medical marijuana and he was smoking it. So he says, "Here, Jim, try this." And I said, "Okay." And like Dr. Zaklin said, instantly I had a relief of my feet and legs. It was miraculous. And then I said, "Oh, this is interesting." And then a couple of weeks later, it wasn't as much. But then I said, "Okay, let me go into this a little more." And I went online. I found Dr. Zaklin, made an appointment. He did an exam, worked me up, and said, "Well, you should go to a dispensary and see what they have and whatnot, and give them your symptoms." So that's what I did, and I started out with CBD and sativa in the day, noonish, whatever, and then later in the afternoon, indica. And I was doing that for a while, and then I go to Integrative Therapeutics, and so I was chatting with them one time, and I said, I don't see the relief so much from the sativa. I said, "Nah, just go with the indica." So I started doing that, just indica, no sativa, and I started doing it later and later for some reason. I didn't seem to need the relief in the afternoon so much, and I've had this discussion with Dr. Zaklin whether or not the indica and CBD are curative or just palliative. And so I think, I was saying, well, it's just palliative. But over the period of a year or so, I've tended to need less. So what I'm doing now is, about 9 or 10 o'clock. I don't take any marijuana during the day at all. In the evening, later at night, maybe 9 o'clock, I'll do 3/4 of an eyedropper of indica and about a third of a dropper of CBD, and boom, I'm good. But I must say, I take gabapentin 3 times a day, 400 milligrams 3 times a day, and ibuprofen twice a day.
How much, Mr. Hicks? How much gabapentin and ibuprofen? So how much ibuprofen are you using, and how much have you reduced your gabapentin dose?
Well, my gabapentin hasn't been reduced. I got up to 400 3 times a day, but I must say it's more for my hands than my legs. My hands have become the focal point of my discomfort nowadays. Although at night, going to sleep at night, the legs are the deal. So, but anyway, the gabapentin helps my hands. I have 3 things going on with my hands: neuropathy, carpal tunnel, and arthritis. So I've got a triple, whammy on my hands. So they hurt a lot, and the gabapentin helps that a lot. If I take it at noon by itself, and then at 4 or 5 I take gabapentin with 2 ibuprofens, and then in the evening I do the same thing, and then the indica and CBD, and I'm good. And so the reduced need for indica and CBD, you say, well, is it curative or not? I don't know. I wouldn't know how to say, but all I know is that I don't need it as much. I'm fine. I sleep very well at night. Oh, and also, just before going to bed, I do puff. I vape a little bit of marijuana also, 2 or 3 puffs, and it seems to help me get me to sleep. So that's pretty much it.
Thank you very much, Mr. Hicks.
Sure.
We will. So you're going to stick around, and we're going to have a discussion after.
Absolutely, sure.
It is my privilege to invite and introduce Dr. Don Levy here. He's an assistant clinical professor of medicine, Harvard Medical School, and he is the medical director of the Osher Center for Integrative Medicine. So, thank you, Don. Yeah, you're just get right out.
So my job is to be a integrative physician and say, what's the big view? How do we look?
Jim, can you mute your microphone, please?
Sure.
Over and out. So in 10 minutes or less, can I give an overview of how an integrative physician would look at a peripheral neuropathy? Can't hear me. So he said, how about, no. Can you hear me in the back? All right. How would you take a look at a patient like this? And I would begin with a conventional workup, as was just described beautifully and quickly. And now I'll tell you a little bit of a philosophy of how we look at pain and just fly over the toolbox from 5,000 feet or so. This is a great quote from a great historian of medicine, Roy Porter, who talks about Western medicine with no particular agenda in mind, but says the big thing about our approach to medicine is we've broken with the, quote, traditional wisdom of the body, and therein lies our strengths and our weaknesses. In other words, in this particular model, the body is a machine, a fabulous machine, wonderful machine, and it may develop a broken part. And the goal of modern medicine is fix the broken part. So that raises a question for clinicians. Should we be more like a mechanic or a gardener? And interesting question, because the mechanic fixes the broken part, focuses on the part, gets it done, is not particularly interested in the rest of the machine. Gardeners have a lot to do with looking at nutrition, the soil, the rhythm of life, sunlight, etc. Making the plant more resilient is one of the things we as gardeners do. I think Western 21st century medicine is a little of both. When it comes to acute pain, I like a mechanic. If I fall off a truck and break my leg, put me back together with screws and such. But I might need some gardening when it becomes chronic pain. And in the modern world, chronic conditions seem to far outnumber acute problems. So what do we do? So that's by way of just saying how we begin to look at someone who's in pain and do distinguish between acute and chronic. Here's the toolbox, some of the toolbox we use, and I'm just going to fly over it. Many people here practice one of these, anything from acupuncture to any number of mind-body behavioral stress reduction approaches to help modulate our pain. All kinds of body work. We offer many of these at our clinic. Movement and massage therapies. The Alexander technique interests me. Craniosacral therapy, Feldenkrais-based movement, etc. Chiropractic's a big part of our clinic. And then you get into more hard to figure out where they fit dietary supplements, botanicals, including cannabis as another component of treatment. And then the other physical therapies that are well known to people. Acupuncture, I'll just fly through a couple of the pictures of these. What's interesting is it's crept into modern literature. This is the Department of Defense, NCAM, National, from NIH, from a conference, I believe. Acupuncture for chronic pain, and something we've offered at times, trigger point inject management with acupuncture needles. Chiropractic care is growing like crazy in the literature, and especially in our clinic, for especially neck, back, and TMJ type pains. All of the body awareness therapies, each one of these slides could be a 1-hour talk of the kinds of slightly different approaches to someone in pain, and some have fabulous application for a given person. I list the Alexander technique separately because it was one of the first over a decade ago to have a fully vetted, randomized controlled trial of it versus competing therapies, and it did very well. There's been another trial since then. Some of the other modalities are catching up as far as research. Like, I can't wait to see more in craniosacral therapy. It's a mystery to me, magical sometimes, and has profound results. Don't ask me how. Our own Peter Wayne, Professor Wayne, clarified the roles of something like Tai Chi, to me, a truly mind-body therapy, and how it can work for pain and other things in medicine. Huge literature growing on yoga, especially yoga and back pain. So what's a thoughtful approach to someone like me who's caught in the position of somebody walks in with pain? I begin with that philosophy. I'm going to be a gardener. I think the mechanical work has probably been done. And now my job is to choose from that toolbox I just mentioned, what's an appropriate modality? Can't give everything to everybody. It's not appropriate. Wouldn't be helpful. The other thing is I assess something that's really important, I believe, which is more than the pain. How much and how is the person suffering? Different words, suffering. I always explain, if we're going to add a mind-body technique, why and how that works. That's a 10-minute discussion. Or if not, the patient hears, oh, it's all in my head. That's what you're saying, and leaves very uncomfortable. And then we can talk about diet and dietary supplements. So choosing is something that's, I think, a skill, because it's way too easy to give everything or try everything. I love it when our team can do a multiple, coordinated, hands-on approach with maybe 2 people working on somebody in sequence, or deciding it's not working, let's try something else, and explaining that to the patient before we try other kinds of techniques. And then, as I said, one of my favorites is to think about what's the difference between pain and suffering. In this book by Eric Cassell, The Nature of Suffering and the Goals of Medicine, I think should be required reading for everybody entering medical school, because it's a lot about what we do as clinicians. Here's when pain becomes suffering. If anyone's ever been in pain, you can relate to this. It feels out of control, very scary. It's overwhelming when I don't know what's causing the pain. That's horrible. When the meaning of the pain is something terrible, or it looks like it's going to be without end. The meaning of the pain, by the way, is a question really important to ask because, for example, I was one of the first patients presented a few years ago for my back pain and my herniated disc, and you wonder, even if you're educated, every time I move a certain way, it's killing me. If I move too far, will I get paralyzed? will something terrible happen, something dire? Until that, well, I kind of knew a little bit having attended medical school, but having a surgeon explain to me, no, you're not going to hurt yourself, so you can try these things. That's critical, because if my interpretation of the meaning is pain, I'm in trouble, then I'm going to be in trouble. Well, one way to assess this, I love this, Sean Mackey at the Stanford Pain Management Unit called it the Stanford Five, and all of his fellows had to ask these 5 questions of every single patient. And if you ask these questions, you will understand this person. What's your belief about the cause of the pain? And it could range from God is punishing me to that idiot who cut me off in traffic to my stupidity and I'll always blame myself, etc. What does it mean? What does pain mean? Like I just said, does pain mean something terrible? Or does it just mean it's pain and I'm going to work through it? What's it doing to my life? What's my goal in pain management? That's a big one because now we give pain a number. And if the number is 7, well, in general, we want to make it go to 0. Well, nobody I know in pain wants a complete 0 because usually that means so much drugs or so much interference that I can't function. They just want to get it down so I can sit at the Thanksgiving table with my family. I can pick up my grandchild, enough to play tennis again. Very important to ask a patient, what do you want? And then what's your idea of appropriate treatment? If someone comes in thinking, I'm not getting treated well till I get an MRI, that should come out in the conversation because they'll leave, no matter how wonderful you are, saying, I got screwed there. I'm going to a better hospital or a better clinic. They won't even give me an MRI. That could be a 5-minute discussion about why you don't need it, but it needs to be discussed. Really good book. The one on the left, The Pain Chronicles, a writer got into pain and visited all the pain clinics, worth a real exploration of what it's like to suffer and have pain. So after explaining, one of the other principles is I need to explain any mind-body intervention I want to give someone. That's a 5 or 10-minute discussion how mind and brain work. Otherwise, again, patient hears, oh, you're saying it's all in my head. This happened when a patient particularly was offered an antidepressant. While the resident stepped out of the room, they Googled it and saw that amitriptyline was an antidepressant, which in low doses could be fine for pain, and was furious when the person came back in until someone explained, no, it even works in rats. Oh, so this is a biologic kind of treatment you're offering me. So important to get into a patient's head. So I always say that you got to explain it. You got to explain that maybe someone like you who doesn't want to meditate could do Tai Chi. One size doesn't fit all when it comes to mind-body interventions. And then we have the big subject, and I'm pretty much getting near the end here, because dietary supplements, it's hard to know where they fit. I have some favorites. After discussing at least if it's an inflammatory condition, an anti-inflammatory eating pattern. There's no such thing as an anti-inflammatory diet, really. It's usually a modified Mediterranean diet. There's a bunch of supplements that I find useful to know about. The simplest is just to see if you're vitamin D deficient, because that will aggravate pain. Alpha-lipoic acid is actually creeping into the literature for diabetic neuropathies, for things like burning mouth syndrome, prevention of migraines. So another natural supplement worth trying. Acetyl L-carnitine is one that might have been considered for our gentleman today. For doctors who are integrative, trying to avoid pharmaceuticals, transdermal preparations where the same drugs are put into a cream, then applied to the area of pain, I think is revolutionary for some people. It's usually got to be somewhat localized. It's not going to work if you have total body pain. You can't bathe in these creams. But a spot treatment can save a lot of side effects from medications. So to summarize it all, you need to, having first done what Dr. Zaklin did, is do a conventional workup. If you're going to go integrative, you need to think through what's an appropriate modality that might work next. Do I understand how this person's suffering and what they think they need? Have I explained clearly how mind-body interventions could help no matter what else we do? And some of the supplements we just talked about, how they might work. And the one that was chosen in this case, or in a funny way, the patient chose and talked to a doctor who happens to know, how about trying medical marijuana? So that's my flyover for how an integrative approach would be.
Thank you so much, Don. That was very interesting. There are a couple of things I want to speak about. One, just kind of noting that in this case, our patient, and I appreciate that you pointed this out, that he still has pain, but he's not really suffering from it as much. So I just want to take a couple of moments, though, and reflect upon integrative medicine as I'm going to take this kind of into a discussion about the endocannabinoid system and ECS and a little bit about cannabis. And we'll leave time for many questions on cannabis so we can kind of all be on the same page. But I want to set an intention and acknowledge this as a poignant moment in my career. Standing here, having had a gracious invitation by Dr. Mehta, standing here with who was a mentor and colleague of mine in residency, both of them, and standing here at Harvard Medical School doing integrative medicine grand rounds, speaking about the endocannabinoid system and cannabis, which is what I understand is a relative first. So I just want to acknowledge that how powerful that is for me, and the way that I look at integrative medicine. So I look at it as a partnership between the practitioner and the patient, in which you're combining both conventional and less conventional, often natural modalities to help elicit the patient's innate ability to heal themselves, right, and alleviate suffering. It's a partnership in which we work together. It combines Western and Eastern philosophies, and really at its core, I also think about it. It used to be the combination of mind, body, and spirit, if you will, but I like to use the term energy, mind, body, and energy, and understanding how energetics come into play here. And I'm going to come back to that because I believe the ECS is really is the touch point for all three. So, as an integrative physician, what do? I help people achieve a state of balance. And the endocannabinoid system essentially is the physiological system that we use to maintain balance or homeostasis. So light bulbs went off when I had first learned about it. And I like this little parable here. The Buddha said many times, my teaching is like a finger pointing to the moon. Do not mistake the finger for the moon, right? The finger is the teachings, but the moon is the truth. And often people are focused solely on the teachings. By the way, Bruce Lee had said this quote in Enter the Dragon. So what's going on in the legal cannabis industry is something similar, right? So everybody is obsessed with this intoxicating molecule THC. It's very effective. It's essential for medical cannabis, but it's really a finger that's pointing to the moon that's cannabis that has so many other compounds in it. Cannabis is a finger pointing to the moon that is the plant kingdom and helping us to understand our relationship with plants. And that relationship really is focused around the ECS in a lot of ways. And so the essence is the ECS, right? It's you can believe in cannabis as medicine or not. It is, and we'll talk about that. But really, cannabis has such a stigma behind it. It doesn't have a stigma? The cardiovascular system, the endocrine system, right? People aren't anti the GI tract, right? So you can't be anti-ECS. So that's where the mind needs to be open, and that really needs to be the starting point. So let's dive into it. So the endocannabinoid system, as I mentioned, maintains homeostasis. So initially thought to help regulate sleep, appetite, memory, and mood, but it really touches upon all of these physiological processes that are involved in maintaining our homeostasis or balance. And I'm going to go a little bit further into that, what that means to be balanced. Right, so here's a question, an infrequently asked question. What's the most abundant G-protein coupled receptor in the central nervous system? Anybody want to take a guess? Dopamine, serotonin. In the back, CB1 receptor gets a prize, right? So the CB1 receptor, the cannabinoid receptor, there are more of these receptors than dopamine and serotonin combined. There are more of these receptors than dopamine and serotonin combined, and I didn't learn about this. None of us learned about this in medical school. That should be a mind-blowing fact, okay? The most abundant receptor in your brain was we were left in the dark on that one. I'm kind of still going through my stages of grief. Actually, I went through them all. I'm still keep coming back to anger over this one. So let's talk a little bit about the CB1 and CB2, right? So the endocannabinoid system is actually 32 different receptors. However, you'll hear typically this cannabinoid 1 and cannabinoid 2 receptor, CB1 in the central nervous system, brain and spinal cord, CB2 in the periphery, the immune cells. That's a gross oversimplification. You can see on the bottom here, this GPPR5 is also thought to be potentially a CB3. We're not there yet, but you do have CB1 and CB2 throughout the body. But most important out of this slide, there's none in the brainstem. You know what the brainstem, well, there's very few. You know what the brainstem is full of? It's chock full of opioid or mu receptors, right? That's why we can overdose on opioids, drop the respiratory drive, and kill ourselves. You can't do it with anything that is directly modifying the ECS, such as cannabis. So as I mentioned, there are 32 receptors. There's about 130 to 140 chemically analogous endocannabinoids. The most well-studied ones are the ones at the top there, anandamide and 2-AG. And just a little bit on how it works. So this isn't necessarily unique to the endocannabinoid system, but the CB1 receptors and CB2 receptors, what you see here is they're sitting there on the presynaptic neuron. And the way that I think about the ECS is it essentially controls the tempo of our existence. Right, so when we're too amped and you have too much, you have too much glutamate excitation happening, then it tones things down, it turns it off. If we're too dampened and you have too much GABA activity, it'll crank things up a bit. And that's essentially what the ECS is doing. So it's modulating what's happening throughout the body. And it's involved in many pathways. It's incredibly complex. That's what the purpose of this slide is. And there have been deficiency, the clinical endocannabinoid deficiency syndrome has been described by Ethan Russo. So if you think about these three conditions, migraines, fibromyalgia, IBS, anybody in this room treat patients with any of these conditions? Just a few, right? Is there kind of a little bit of a nebulous flavor to many of these? We don't know exactly what's causing them. We don't know why people have these, right? So there's an interesting paper that Dr. Russo wrote and followed up on. I encourage you to read. Other syndromes that are associated or conditions associated with possible deficiencies, schizophrenia, MS. MS patients have lower endocannabinoid levels in their cerebrospinal fluid, Parkinson's, anorexia. And what's interesting is that many of the interventions that Dr. Levy alluded to also modify the ECS. So there's a theme here, right? I think you mentioned probably every single one on this list. Medications also involve the ECS. Acetaminophen follows an indirect CB1 pathway. Okay, so we've been using our ECS since time immemorial, and we've been optimizing it and engaging with it. We just didn't realize it. Natural medicines such as polyunsaturated fatty acids will increase 2-AG and anandamide expression. Probiotics increase CB2 expression in the gut. Alcohol, caffeine, chocolate, right? It looks like a party, but there's a joke there, but there's also not, right? These are intoxicants that people use to modify their experience, to help them to kind of feel, to relax, right? And to feel kind of integrated in a way. Not that you need alcohol, caffeine, and chocolate. That is a good part of any integrative program in some ways. Would you not agree? So, and other herbs. And if you notice here at the bottom is the first that I'm mentioning, cannabis. So let's talk about what the ECS is, and here's really I want to make my essential point here. So the runner's high. Raise your hand if you're familiar with the runner's high. So most people here, raise your hand if you think it's due to endorphins. Everybody who raised their hand. So the runner's high is actually due to endocannabinoids, right? The thought is that you're running, you're feeling pain, you're producing endorphins so that you don't feel pain. And you really shouldn't be feeling too much pain when you run. You probably do release some endorphins, but let's talk about the ECS in lieu of endorphins. How about you're running and that reptilian brain, that part of you senses that the system is stressed. You're running from the predator or you're running after the prey, right? And so what happens is while we're stressed, while we're amped, we need to have a relaxed, focused state of mind. So what happens is the signal is sent, the neurons create on demand from the phospholipid membranes. So these are not stored in vesicles, by the way. Anandamide, named after the Sanskrit word for bliss, is created on demand, and the brain is bathed in anandamide. Now you're running and you're clear-headed and you're focused. When you stop running, you feel a mild euphoric sensation that is analogous to a low-level sensation with cannabis. That's the runner's high. So if you've exercised and felt euphoric afterwards, you've experienced the ECS, you've experienced the runner's high. I want to talk about that for a moment. So let's look at these organ systems where the ECS is not necessarily an organ system, but it really needs to take its place here. So how do the lay people understand basic physiology, right? When they work out and their muscles are sore for 2 days, they know it's okay. If it's a week later, your legs are still hurting, you better go to the doctor. A spot of blood on the toilet paper is different than a bowl filled with red blood, right? If you're climbing stairs, a little bit of sweating and an increased heart rate is different than an elephant sitting on your chest. So what does physiology help tell us? It tells us if we are safe. What does it mean to be balanced, right? It means that we are safe, okay? It means that there is no threat in my immediate periphery and I can be in a present state of mind. So, for example, right, that's what we do is we're constantly assessing risk in our environment and we're assessing whether or not we're safe and whether or not we can be present, whether or not we need to anticipate something that may happen, i.e. fear something in the future, i.e. have anxiety, right? Or whether or not something in the past that happened now has kind of mired our view of things and we're therefore depressed. So if we're too anxious, what will happen is the ECS turns on, cranks out that anandamide, and allows us to calm down and stay more focused and relaxed. If we're too depressed, we don't have the gusto to kind of, if you hear that noise, we're not going to pop up and know what's that sound that I heard, right? So the ECS will amplify things and allow us to be a little bit more alert. So really, the endocannabinoid system becomes the story that you can tell yourself. It becomes a story that says, you know what? How's my ECS? I'm feeling a little bit, we could say, famished, right? I'm a little famished right now. I'm just a little off. What's up with that? There's nothing I could put my finger on. And the mind starts searching for a story. Well, here's a story that you can tell yourself. Maybe I'm not tonified. Maybe I need to go for a walk. Maybe I need to do some meditation. Maybe it's time to have my evening cannabis. And just taking it a step further, and this is just kind of food for thought, right? In the traditional Chinese medicine, 5 elements, you look at the liver, they're not really talking about the organ, although it's based off of that. There's a liver energy. So my question is, right, and this is for discussion, what's the ECS energy? What's the ECS equivalent to traditional Chinese medicine? Is this that web that has no weaver? Not sure, right? These are all great questions. So I only have a few minutes for Cannabis Basics, and I don't want to belabor it. The basic fact is it's a complicated plant. If you want to just think about cannabis as a medication, it's one of the dirtiest drugs out there, right? It's up to 500 compounds, many different receptors involved. We have our cannabinoids that people are familiar with, THC, intoxicating at high enough doses, not always intoxicating. CBD, definitely psychoactive, not intoxicating. You have the precursor to THC, which is a potent anti-inflammatory and is not intoxicating. You have other cannabinoids such as THCV, which helps suppress appetite and regulate blood sugar. And then we have the terpenes, which are the essential oils that give plants their characteristic odor and flavor, but also add to their medicinal property. So linalool found in lavender might be found in certain strains that are calming, or limonene, which is activating and invigorating, would be found in those what we call sativa strains, as Mr. Hicks was referring to, for daytime use. Lemon is uplifting. Your cannabinoids and your terpenes create what's called an entourage or ensemble effect, and that elicits a specific response within the physiological system and results in what we call strains. The terminology is indica or sativa. You can just think about it as relaxing versus stimulating. Again, we're in like 1950s medicine understanding of cannabis, so eventually this nomenclature is going to evolve. I like to show this slide before I talk about cannabis as medicine. Before I talk about cannabis as medicine, I want to make sure we're all on the same page, that the object in the front is round and it's revolving around the object in the back. If you think differently, then I guess you can think that cannabis isn't medicine, but I'm here to tell you that it is medicine. There's no question. We look at the National Academies of Sciences, Engineering, and Medicine. They looked at over 10,000 abstracts. They came to similar conclusions that have been concluded previously in the literature, which is that there's indisputable evidence that cannabis helps manage chronic pain, nausea, vomiting, chemotherapy, spasticity, and MS, and seizures. Okay, there's substantial evidence it's an effective treatment for chronic pain. I don't think Mr. Hicks really cares what the evidence shows in the literature. Okay, it's always important to make that point, right? So, just a couple, just to kind of finish up here, I want to point out a few more interesting and more exciting studies that are happening. So Stacy Gruber over at McLean on the Marijuana Investigations for Neuroscientific Discovery, the Mind Institute. So she did a couple of studies where she looked at a group of medical cannabis patients, and they actually had an improvement in executive function, which is fascinating. And if you look at their medications, opiates were reduced by 43%, antidepressant, mood stabilizers, and benzos were all reduced. It was a small number of patients, but she did the study in another group of patients, and she showed on fMRI that these patients actually had changes in their cingulate cortex and frontal lobes, and actually compared those changes to healthy subjects, non-cannabis subjects from other studies, and they were similar, suggestive of some kind of normalization with people who responded to medical cannabis. And in this study, she showed, look at this, opioids, 48% reduction, benzos, 47%, antidepressants, 22%, mood stabilizers, 28%. So we are seeing that, one, there is substantial evidence, but we are also seeing that we are cutting medications in half, and this is what I'm seeing in my practice. Opioid prescriptions have dropped in states that have both adult use and medical cannabis. In Massachusetts alone, there's been a 4% decrease in opioid-related overdose deaths. And since 2016, there's a 30% decline in opioid prescriptions. They attribute it to Mass Pat. I would call them out on that one. I mean, we got to grab at least 5 to 10% of those attributed to cannabis. So just some brief safety concerns. My contraindications: pregnancy is a contraindication, schizophrenia is a contraindication or family history thereof, immunocompromised, no inhaled medication. Typically with my patients, I don't recommend they inhale medication anyway, but you do need to monitor immunosuppressants. And, driving is a concern, but less so with medical cannabis. I'll touch upon this briefly, but there's adult use, right, which is focused on intoxication, on getting high. That's the goal. And then there's medical cannabis, which is targeting symptom management. And intoxication is a side effect, often an unwanted side effect in many of those patients. So the bridge between the two is therapeutic, right? So enjoying some cannabis with some friends on a Friday night, instead of some wine or instead of some beer, can be quite therapeutic if you're having some belly laughs, right, and you're connecting with each other. Finishing up, so the medical use of marijuana program in Massachusetts, as of August, there were 60,000 provider certifications, only 262 registered healthcare providers. You have to do a 2-hour CME course in order to certify, but the problem that I'm seeing, right, is you have 36,000 physicians, 6,300 nurse practitioners, so around 42,000 providers, and really only 0.6% are eligible to certify for medical cannabis. I think that is because they just simply don't know enough about it, but the model does need to change. This is a rediscovery. It's not something new. This room in particular can appreciate that this has been used for 5,000 years in both traditional Chinese medicine and Ayurvedic medicine. It's been less than a century since pharmaceutical companies were producing pounds of cannabis to make tinctures that your grandparents were using to manage their headaches and their sleep and their moods, right? So the fact that it's a rediscovery doesn't necessarily justify its use, but now we've used science to identify the ECS and we understand why it's working. Right, so the perception that everybody has about medical cannabis is not the reality. This is the reality that's happening in my practice: THCA, capsules, gummies, tinctures. So without further ado, that's what I have, and I think we'll open it up for a discussion between myself, Dr. Levy, and Mr. Hicks. Thank you.
Okay. Well, thank you, Ryan, for the really wonderful setting up the stage for an amazing discussion. Thank you, Don, for your insight as just with years of experience in integrative medicine, and thank you again, Mr. Hicks. So what we'd like to do at this time is invite questions from the audience and really to have discussion around this topic. So yeah, please, and there's going to be a mic going around, so please speak into the mic so that Mr. Hicks can hear, as well as there are people who are being live streamed, who are watching this through live stream.
I've actually had several people in my practice trying the indica for sleep, and 4 out of 4, they stopped before they got to a good dose. They're too heavy a head when they get up in the middle of the night to use the bathroom. So I'd like to know how you got successful, and I'd like to ask the patient, what's the formula that you mix, or is it all indica to sleep?
So, Ryan, do you want to start, and then Mr. Hicks?
Sorry with that. So you have to keep in mind that there's a couple of points. So we may be looking at a genetic variation that we have no idea what it is right now. Right? Some people lack the gene for alcohol dehydrogenase and can't touch a drop of alcohol. Some people touch a drop of caffeine and get the shake so bad, whereas my father-in-law can have a double espresso and go to at 10 o'clock at night and go to sleep. I would be up till 10 in the morning. So I think it's safer to assume that with cannabis we're going to see similar variations in response.
Exactly.
And so we need to consider that. There's a couple of other factors too. As I mentioned, the different strains. So the cannabinoid profiles could be completely different. So with Mr. Hicks, he's been using the same tincture. That tincture could have one terpene in it, and it's that terpene in combination with THC that actually helps him get to sleep. The other factors with patients often is they give up a little bit, so they titrate up too quickly and they give up too early. So what they need to do is start at several just drops and keep with that for
Exactly what they all did.
but keep with that for a week, okay? Then go up 1 drop, go with 5 drops for a week, go up another drop. I'll often introduce people to meditation, start out with 5 minutes and incrementally increase that. So I tell them increase your meditation as you increase your medication, right? Go up 1 drop, go up 30 seconds. And so, I mean, the short answer, and I'd love to hear from Mr. Hicks too, it's just trial and trial. And I think probably a really prolonged increase.
Any other factors you would blend in, or will the patient?
I would
talk
add
about that?
I would try other tinctures as well and other strains of cannabis as well.
Mr. Hicks, do you have any comment?
Well, I don't use it indica to get to sleep so much as to alleviate the itchy, scratchy things in my legs. Although I guess it's the same thing. I don't know. And getting up in the middle of the night to go pee is right. You were a little bit. The first time I get up, I'm a little wobblier. I don't have a head. The tincture never gives me a head. I don't get high. But I'm a little wobbly. My legs are a little wobbly. But it's manageable. It's not a problem. And then the second time I get up to pee is, it's nothing. It's gone by 4 o'clock in the morning. So there's that.
You can also add CBD. So when you add CBD to it, so CBD can sometimes put people to sleep, or sometimes it makes them more alert, but CBD will widen the therapeutic window of THC and allow them to tolerate higher doses without intoxication.
Thank you.
And one other question, just out of curiosity. Is it possible to make a THC that doesn't make you eat?
So it may not be the THC that's causing an increased appetite. THC in and of itself, it's likely, again, the combination of THC with the certain terpenes. So when you have certain terpenes like pinene, beta-caryophyllene, or more of the sativa variants, they don't make you as hungry as some of those what we call indica varieties do.
I just say one thing, that I think this is all because we're in such primitive, woods regarding all this, because there's so many active parts and so many things that some of the companies are at least printing out on their label how much THC and THC variants, how much CBD, maybe even some of the terpenes. Eventually we'll get to know a pattern, and doctors will be more able to start someone somewhere. I always tell people, keep an absolute diary clearly of what you're taking, and you can then show that to someone who's more knowledgeable and say, I think I see what you need. A little more CBD, a little less this, a little less that. We're really in the 50s for sure. We're just beginners.
Good. Tina.
Still in reefer madness.
Okay. Good. Tina.
Thank you very much. That was very informative. I'm wondering if you can comment on addiction potential and if you think history of substance abuse is a contraindication.
Yeah, I appreciate that. So let me answer the second question. So cannabis is looked at as a gateway drug. That's been kind of this gateway theory. It's been disproven, or actually it's been proven to be a gateway off of medications. As you can see, it's an exit drug, right? So as you can see, you're reducing opioid doses. It works synergistically with opioids and can help reduce both side effects and can also reduce tolerance. So so cannabis is, as an intoxicant, it is not toxic, okay? It's less toxic than water. That's a fact. You can kill yourself with water before you kill yourself with cannabis. However, it's not completely safe, right? You can easily kill yourself with cannabis if you drive with it or do something stupid. So it's not a contraindication. And I think that, in terms of addiction potential, right, that's like a whole day that we can talk about it, right? So, I mean, defining addiction, I mean, you're talking about dopamine reward pathway, right? I'm addicted to health food. I'm addicted to exercise. I'm addicted to water, literally, right? I mean, right now I'm addicted to caffeine. I haven't gone through the process of decaffeinating myself to avoid the headaches. But the fact of the matter is the withdrawal symptoms are minimal. So no, and when you're talking about, again, looking at the recreational, the therapeutic bridge, and the medical, the addiction potential with medical, I believe, is really minimal if used appropriately, right? It's the same with opioids in a lot of ways, too. The opioid addiction is due to misusing them.
Don, your
I'm really
thoughts?
concerned about that, especially for young people. And when you look at the literature, they list 9%, which is a low addiction rate. Things like cigarettes are way more addicting. But I don't care. It is addicting. There is a withdrawal syndrome. And almost all of the people who have this began in teenage years, sometimes age 13 to 18. And they started recreationally and are now having a problem. There's very few who start medically that get addicted. And I think that's important. I do worry about what age people should be using these substances.
18 is the kind of, other than medically for a medical condition, but I mean 21 is really the legal limit, but at the very earliest 18 in terms of brain development. The later, the better.
Okay. Yeah, behind, and then up at the top. Yeah.
Can you just speak up a little bit about the role of schizophrenia interaction with this drug?
So there is a link between the CB2 receptors and schizophrenia. It's somewhat controversial in the sense of schizophrenia being a contraindication, because the reality is the number needed to treat is in order to have one person have schizophrenia essentially be revealed, if you will, is quite large. But cannabis in high doses can cause psychosis. And I think, that's basically, there has been an association with heavy cannabis users and development of schizophrenia. So for those reasons, I take a conservative approach, and it's a contraindication. Whether or not a schizophrenic could use, CBD or very low dose medicine as a mood stabilizer, I think that's to be determined. But again, we kind of have our hands tied just because there's so much we don't know.
Okay. Yeah. Yeah.
In terms of getting ourselves out of the 50s, how are we learning more about the different kinds of receptors? How are they being differentiated? Is it the neurophysiology, or is it how they're responding to different strains of cannabis? I'm just curious to know more about that.
It's both. There was an exciting announcement yesterday. I think the Harvard Medical School just got a $4.5 million grant to study cannabinoids, right? So it's two neurophysiologists. Forgive me, I can't recall both of their names off the top of my head, but so that's one area. You do have a lot of research going on in Israel. That's kind of the mecca for medical cannabis. Technion University and Dedi Miri is studying cancer cells and cancer treatment. And then I think we're starting to see clinical research. So I think that it's a combination of all of them. And I think we will catch up quickly. A colleague of mine said, cannabis years are like dog years. In like 1 year of cannabis, we catch up 7 years. So I think we'll get there within the next few years or so.
Mr. Hicks, I have a question for you. If you could speak to some of if you faced any stigma in sort of thinking about this treatment when you talked about with your other providers.
Well, my main form of providers is a VA, and of course they can't, they're restricted by the government. But I'm fully open with them what I do. I tell because they want to know what my behavior is, and they don't comment because they're not able to. I go to private doctors and whatnot, and they're fine. They don't have any problem. They don't comment at all about it. And as a matter of fact, I don't care. But I don't care what anybody says. I just know what I do, and it works. And like that.
I want to make a couple of points about Mr. Hicks, actually. So one, I just have to correct that I did give him specific instructions on what to use. I didn't tell him to go to the dispensary and get and ask.
I didn't want to say that because I thought you were going to get in trouble. But
I'll call him. No, I won't. But I appreciate it. So I did tell him specifically. The other thing that was interesting is that I didn't mention is that I believe, and Mr. Hicks, correct me if I'm wrong, it took a couple of weeks before it really kind of kicked in, and that's an interesting piece of information that I've heard, so you kind of have to stick with it. And the other interesting piece of information is that he's needed to use, so his ibuprofen has been reduced, gabapentin has stayed the same, but he's needed to use less and less cannabinoids. So whether or not his ECS, right, is beginning to kind of wake up and get tonified, if you will, that's right.
Who knows?
That's a good question. So maybe you could just comment on that briefly.
Well, it just, I started out with what you said to do, and I didn't want to say that, but anyway. And so, for few months, I did the sativa during the day and the indica at night, and CBD both times. And it just sort of, at one point, I said, well, I don't know why I'm doing the sativa. I'm during the day. Who cares? I don't feel the symptoms and whatnot. And at the dispensary, they said, yeah, indica is what, gets you numb for your body and whatnot. I said, okay. So I just stopped using sativa, and it was fine. I didn't have any problem with it. And I was doing indica twice a day, 4 o'clock in the afternoon and 8 o'clock at night. And if I was going out at night, I was having a little bit of problem with driving, and I didn't like that, and a little bit wobbly, and I felt like my feet had pillows on them during the evening. So after a while, I just stopped doing it at 4 o'clock because I didn't really need it, so to speak, and then because it doesn't really start bothering me till later, and so now it's like what it is, just the evening, late evening. And I don't know, like you say, I don't know if it's curative, but I don't care. I mean, maybe it is. And I don't know how to do that study, but, anyway.
Well, I just want,
Say this is making it very clear why everyone, if you want to give one piece of advice to someone using it, is keep a diary. Keep a really clear diary of what you're doing, when you're taking it, what you're taking, so that someone with knowledge you could bring it to might be able to modify it, or someone else will eventually be able to look back and say, I think I see what was going on. But there's no way to keep track because everybody just starts messing around and dropping doses, and their friend has a better strain, and God knows what that is. Keep a diary. Keep a log.
So I wanted to just run to time, and I know this is this is an amazing topic that obviously requires much more discussion. So we would invite you to join us across the hall and with over coffee and some light refreshments to continue this discussion. But first and foremost, thank you, Mr. Hicks, for sharing with us
welcome.
your story. And thank you, Ryan. Thank you for really a provocative discussion, and thank you, Don, for just sharing some important insights as we begin to address this very important topic, particularly amongst all healthcare providers, but obviously very important in the field of integrative medicine. So just to before we just adjourn here, just a reminder, please come back next month on June 4th. Our topic is Mediterranean diet to reduce cardiovascular disease and other chronic disease of aging. In July, we will have a panel discussion on looking at the role interface of integrative medicine and climate change. And you'll see our subsequent topics. Just grab one of our grand round sheets and you'll see it. So we look forward to seeing you all here. If you aren't on our mailing email listserv, please sign up, and then we'll make sure that if you haven't signed in, sign in, and then we'll make sure that you get our emails, or you can sign up through our website on oshercenter.org, and we'll see you across the hall. All right. Thank you, everyone.